So our speaker is here, Cynthia. Cynthia, hello. How are you? And welcome to our meeting. And are you here with your colleague?
I am. That's Frances. Frances Amt. She's coming
Hi,
up as
everyone.
Frances.
Oh, yes, Frances. Hi.
Hi.
So
Frances.
welcome to you both. Yeah. So look, we and Belle's here and Kathy McNamee's here. I think we've got a quorum. So look, let's open with a welcome. And I'll start with an acknowledgement of country. And I just wanted to formally and respectfully acknowledge the land on which we are broadcasting tonight and the lands on which some of you are receiving, being different from where I'm broadcasting from, or we're broadcasting from, the land of the Wurundjeri people of the Kulin Nation, and to pay our respects to elders past, present, and emerging, and to acknowledge that this land was never ceded, sovereignty was never ceded over this land. When you, if some of you are new to the meeting, I think there might be a few that are new. If you could introduce yourselves on the chat. Otherwise, a very warm welcome to the Western Public Health Unit, Cynthia Pollard and Dr. Frances Amt, who are going to talk to us about the work that they're doing with the Public Health Unit in their area. And we're also going to have a bit of a chat about some recent publications that showcase the work that you're all doing, and just showing how important it is. I think, Kath, you shared those.
There's a link.
Yeah, there's a link to those articles for you.
Yep.
And as always, we'll have an update of what's happening around the state from Carolyn when she joins us from 1-800 My Options. And there is always time for us to go around and just news from around Victoria, any updates of new services, service development, service cooperations or closures, or anything that we need to discuss.
Carolyn's just letting us know she can't make it.
Oh, Carolyn,
big apologies. Yeah.
Did she have anything she wanted to share?
Yes.
So we just,
will I do that now?
Yeah, we've just got a text from Carolyn.
Please let the group know we continue to be busy. We've soft launched web chat for people to access 1-800 My Options. If they prefer that.
What's that? What's a soft launch web chat?
You know, some people might be able to explain it better than me, but often when you're shopping, a little prompt comes up. Hello, can we help you? Oh, that's my understanding. Where's Kath Bateman? I saw you there before.
Yeah, I'm here. Happy to explain. So basically, soft launch means they haven't announced it. It's just appeared on the website without any fanfare. That's what soft launch means.
Okay.
And web chat is that, yeah. So instead of calling 1-800 and talking to them on the phone, you can essentially, it's like text message, or instant messenger on the website. So instead of calling and saying, this is my situation, where can I go? You can text chat. So it's great for people whose language isn't perfect, who's a struggle on the phone. With disabilities, that means that using phones is difficult, or like they're sitting on the tram on the way to work and they want to find out, and they don't have to be on the phone, they can chat away.
Yeah, thanks, Kath.
Oh, that's really good. Thank you, Kath.
But in the inside story. And she says, Carolyn says it's going well, and we've had higher rates of young people and more STI queries via the web chat than we would normally do on the phone. So they are probably accessing a
It's exactly right, Kath, isn't it? Yeah, different groups. So that's really, really good. As always, 1-800 being incredibly flexible and creative and leading the way with these things. Kylie Wagstaff is new to our meeting. Kylie, would you like to wave your hands up in the air? Yeah, Kylie is from Albury Wodonga, from the Aboriginal Health Service there. Kylie, would you like to say a few words about what your health service does and how you heard about our group and what you would like to get out of involvement?
Can't really remember how I heard about the group, but somehow I ended up on an email list, and I've kind of known when the meetings were on. So I'm the practice nurse, and the clinic coordinator is my other title, but that basically just means ordering stuff and cleaning stuff and putting out spot fires on a day-to-day basis, sort of thing. We have a clinic manager as well, and so I'm a midwife as well, and certificate in sexual and reproductive health. Yeah, so we do, we do MTOPs, but I feel a bit disconnected, really don't even get across the border to Clinic 35 much. Yeah, so I just thought I needed to touch base with a bigger group and learn more.
Oh, that's great. And do you ever have refer to each other across to Clinic 35?
Not a great deal, to be honest. Yeah, we would mostly manage in-house, I think. Yeah.
Well, I
But-
think we mentioned to you before that we're big fans, Kath and I, of the swimming facilities in Albury Wodonga, and we have done a couple of visits up there. And just even meeting you tonight, the next time we do a visit, we could maybe do a combined visit.
Yeah, it would be
Yeah,
great. Yeah.
And introduce you to each other, etc. Just to have a bit of synergy.
Yeah.
So we will have your contacts now that you're in the group. So
Yeah.
a very warm welcome.
Thanks.
Anyone else new to the meeting? Who's that?
I am, but I've just put my information in the chat, but it's nice to see some very familiar faces across the participants tonight.
Oh, that's Sarah. Hi, Sarah. You're the nurse practitioner candidate at sexual health.
Right, you before you
Ears
came
must have
on.
been burning. I saw it on OzCap, so welcome aboard.
Yeah.
I've sent you a message too, so and my email's in the chat if you want to connect.
Great, thank you so much.
Congratulations. That's
Yeah.
great. That's
Exciting.
great. Sarah, what's your family name?
Harwood, Harwood.
Yeah. Oh, well, great. And thank you for coming along tonight. That's great.
You might see a naked little body in the background at some point, but I'm hoping that the blurred background will give some privacy to the family life behind me.
The juggle's real.
Well, without further ado, Cynthia and Francis, would you like to take the floor, as it were, the virtual floor, and tell us about the work that you're doing? We're really keen to hear.
Sure thing, and thank you for the invitation. And Kath, if you could keep us to time, I know we've got 15 minutes. I do tend to waffle a bit.
Well, you've got a little bit more, Cynthia, because you didn't have the 5 to 10 minute presentation from 1-800.
Okay,
Yeah,
all right.
more
Well, we'll see how we go for time.
I'll keep time anyhow.
26.
Thanks. So I have been to this meeting before. A big fan of the work that you do and how you collaborate among other clinicians and your peers. My name's Cynthia. I have a nursing background. I'm a clinical nurse consultant. I have worked in the sexual and reproductive health, HIV, STI space, family planning and Marie Stopes for probably 30 odd years, closer to 40. And I have been with WEFU, so that's the Western Public Health Unit, for just over 12 months. WEFU applied for an expression of interest for a CNC that was initially funded by the Department of Health, and that was to look at our local catchment SRH, so sexual and reproductive health and viral hepatitis service gaps and ways of system strengthening, and that aligns with the Victorian Sexual and Reproductive Health Strategy 23 to 30. That was short-lived. DH pulled their funding after 6 months. I was one of 4 nurses that were employed. So Rosie is one of me. She's the NEFU counterpart, and then Gippsland also have a clinical nurse consultant and also the Barwon area. So all of the LPHUs stepped in and took over the funding for our positions, and some of us have been extended for another 6 months. So in total, we'll be in our positions for at least 18 months. Beyond June 30, we don't know. So we've continued to look at some very localised issues and implementing interventions alongside our community. But just for those that don't know, WEFU's catchment extends 1,419 kilometres across central and western metropolitan Melbourne. And our catchment includes 8 local government areas, and they're Brimbank, Hobsons Bay, Maribyrnong, Melbourne, Melton, Moonee Valley, Marybeck and Wyndham. We've got 6 public health services, 1 Aboriginal service and 1 primary health care network. Actually, we have another Aboriginal health service new in St Albans, so that's now 2. We've got 4 community health services, 460 early childhood services and 105 maternal and child health services, 93 aged care services, 3 ports of entry to Australia and 7 prisons. So we've got a very diverse community. So we've continued, in my role, we've continued to look at local services, conducted mapping and gap analysis. WEFU works under a matrix model across a multidisciplinary team. So we have our epidemiology, our data and epidemiology team, our medical team, our health protection team, population health promotion. We have our health protection, so that's our public health officers looking at disease profiles, etc. Comms, and we have our senior leadership. We've got our key stakeholders are a variety of services, but mainly one of our biggest key stakeholders is Gen West. I'm sure you all know Gen West and the work that they do. So that's enough about me. I will hand over to Frances.
Thank you, Cynthia. Can everyone hear me? Good. So my name's Frances Ampt. I'm the lead epidemiologist at Western Public Health Unit, and I'm also a public health physician by background. And I've been at WEFU since nearly its inception, which was back in, well, it was late 2020. I started in early 2021. And we've kind of grown from really just doing COVID epidemiology to now a broader range of population health and communicable diseases, which is I'm really enjoying because it ties in a bit with my background is more in my research background is in contraception and contraceptive health promotion and sexual and reproductive health. So it's been really great to be able to work on this particular topic and take a bit of a data lens to it. And I also, Cynthia thought it might be of interest for me to mention sort of some of the work I've done previously. So I did a PhD with the Burnett Institute, where we actually worked on a clinical trial, not clinical trial, but a randomized trial with sex workers in Kenya. So I spent a bit of time there doing field work, trialing a mobile phone intervention to try and increase LARC uptake and reduce unintended pregnancy. And that kind of sprung from an observation that there were a lot of HIV prevention trials and things in that population, which they had difficulty because a lot of the women kept getting pregnant, and realized it was a real gap in terms of there was a lot of focus on STI prevention, but not necessarily pregnancy prevention. So that's kind of where that sprang from. And I'm happy to talk more about that if people are interested later, if there's any questions. But yeah, that was the sort of background I had in this area. But I wanted to just now talk about the project we're doing at WEFU that Cynthia is leading, and just sort of some of the data on long-acting reversibles and MTOP and that kind of thing within our catchment, and how we kind of came to an idea of what's going on and where we might want to prioritise our efforts. So I'll share my screen if that's okay. I've just got a few slides to show. A second, sorry. I'll see if this works, sorry. Okay, can you see the presentation screen there? Great, okay, cool. So the first thing we wanted to look at was, we were kind of looking at what's the sexual and reproductive health demand in our area, and then also to whatever extent we can, look at what sort of supply is there, what providers are there, and where are there gaps between demand and supply. So we didn't have any particular any new or exciting data, but we were just trying to use what's out there publicly and interrogate it in as best way that we can. So we looked at the Victorian Women's Health Atlas data. So I'm sure a lot of you would be familiar with that data. It's just rates of termination, MTOP and STOP, LARC use, and a number of other related indices by local government areas in Victoria. So we looked at those by WEFU and by year. So they've got them for the last 5 years for most of the indicators. But it was kind of tricky to get a sense of how to compare indicators within each LGA. So to get a full picture of that LGA, to be able to kind of say, like, in Hobson's Bay, where are things at in terms of LARC use, MTOP, etc. And then also to kind of compare across local government areas. And also the data on the Health Atlas is, there were different sort of population denominators. So some of them used the among all women or among all women of a certain age, and it was difficult to compare across them. So what we did was take those data and then recalculate them using the estimated resident population. So it was the population estimated by the ABS to be accurate at that year. So we weren't getting any, because one of the things about WEFU is that it's sort of a growth corridor. So population has changed quite a lot over years. So we wanted to make sure that was kind of really representative. And also just taking that population to be the women aged 15 to 49. So we weren't getting any misleading results by the fact that some local government areas have a very young population or a very old population. So this is the kind of key graphic that I developed from those data. So what this shows is the orange bars are the population of women aged 15 to 49 in each of the WEFU local government areas. So those local government areas are arranged by their MTOP rate. So you can see that purple line at the bottom is the rate of medical terminations per 1,000 women of reproductive age in each of those local government areas. And then the orange bars, sorry, I mentioned that was the population. So you can see that this gives you a sense of how many women there are actually who may be needing services in those areas. It's the MTOP rate is, and in fact, for all indices, there was really significant need in Wyndham, and Wyndham has both high relative need in terms of the rates of indicators, but also absolute, because they have a very large population of women of reproductive age. And they've also consistently had that pattern for the last 5 years. Sorry, I should have said this data is just from 2020, but if you look at over the 5 years, that's been the case. So generally with the MTOP rate, sorry, I should also mention the dotted lines here are the Victorian averages for each indicator. So now if you look at the LARC rate, that's in green, that's low across the board at around 27%, and lower across the Western Public Health Unit. And then we've also got the birth rate there, and kind of interestingly, the birth rate sort of mirrors the MTOP rate in terms of the order of those local government areas. So we've got Wyndham really coming out as a key need, Melton to some extent, but slightly less so. Hobson's Bay was interestingly quite low, high rate of MTOP and high birth rate, which is sort of surprising for given their small number of women in that age category. And Melbourne generally looks good from these data, but you have to really take that with a grain of salt, because there's a very large temporary population in Melbourne, temporary migrant population and international student population that makes these rates look lower than they may actually be in terms of the longer term residents there. So that's the kind of overall graph. We also looked at adolescent birth rate, which and both of these graphs are really trying to get at what unintended pregnancy might look like in these areas, because we obviously don't have a measure for unintended pregnancy, but adolescent birth rate can also give us some indication of that. And Brimbank also came in as an important LGA there, both in the size of the adolescent population as well as the birth rate among that population. And then we looked a little bit at supply as well, using that Health Atlas data, looking at where the providers of each of the services were, as well as looking at 1-800 My Options data and mapping that across our catchment to kind of see where the real gaps were. So I'll just show you, this was the map that we developed from the 1-800 My Options data, which shows the location of medical termination providers in pink, surgical termination providers in blue, and pharmacists in orange, overlaid on the population density of each of those areas. And you can really see very sparse kind of service provision in the outer suburban areas, and a few like little pockets that are circled in red that is where the population's a bit denser, so that darker purple, but there's very little service provision nearby. And when we looked at the Health Atlas data, these were more or less mirrored, except the Health Atlas data could show us the actual number of services provided, whereas this is just where providers are located. So, sorry, that long way of saying kind of what we identified where there's particular need in Wyndham, as well as in some other areas. So I might hand it back to Cynthia to talk a little bit about where that led us next.
Yeah, thanks, Frances. It's great work, and Frances has done a lot of this work. So we decided we would develop a program to improve a defined aspect of need and opportunity for some system strengthening. We found, the service provision of MTOP is a very difficult space to work in, as you all know, and certainly if you're involved in MTOP action groups, etc., you know how difficult it is to get GPs on board. So we looked at it from a health prevention aspect, and it's like, is there a gap in knowledge of women living in these areas? Is there a gap of providers? Is there a gap of health workers that are working in these areas? So we entitled the project Improving Best Practice Reproductive Health Counselling Access and Uptake in Wyndham. So essentially we're wanting to create a resource that can be used by some of our stakeholders that have a lot of access to the community in Wyndham. We're currently looking at our stakeholders as Gen West and the bicultural workers and multilingual workers that work within in that space. We've also looked at partnering with maternal and child health nurses, which are council-run, council-funded or down from the department. So we've basically had some initial meetings with them, and they're all both on board. They're very excited to think about, what we can offer them. So we're looking at hopefully adding value in the way of creating a resource that can be used when you are talking to women about contraceptive options. And certainly we're looking at promoting LARC as the most effective. A lot of resources out there still provide information on contraceptive in huge amounts of detail, which is not that accessible for people of non-English speaking background, even young people. So we're wanting to create a resource that is really user-friendly, possibly different resources that are in language, or at least links out to resources that can be used that are best practice. As we know, LARC is best practice contraceptive, but condoms always come first for some reason, and we just don't get that heightened alertness to LARC. And a lot of the people that provide information or education on contraception in the Wyndham area don't have a clinical background. They often will review or give out information just on contraception options, but not really drill down on the most effective methods. It's a very simple idea, but both the multicultural workers and maternal and child health nurses are very keen to come on board and work with us to amplify some of that work. It's still in its early stages. We're hoping to get some interventions underway in the next couple of months. And as you know, my role will be, don't know what my role will be in June. So we're hoping to have it all wrapped up and evaluated by then. It's kind of a proof of concept that can be used in other LGAs within WEFU, and obviously can be used in other LPHUs as well. So we are at this point of developing the resource. We haven't done that yet, but that's part of the plan. And yeah, we hope to deliver this all in the next few months. Yeah, so that's basically it in a nutshell. Frances, have you got anything to add that I may have missed around the project?
No, I don't think so. I think it's just that sort of tricky balance between looking for something that'll have some sort of system impact, but wanting to be simple and implementable and filling a need sort of thing. So we kind of in WEFU we kind of try and use a model of where we take what's already existing and amplify it or link or coordinate, rather to try and avoid reinventing the wheel where there's a lot of players in health promotion in general. So, yeah.
And one of the best resources out there is the Family Planning Alliance. It's an A4. You've probably all seen it. It's got the pictorial images of the different types of contraception, but it's ranked in its relation to efficacy. From what I understand, it doesn't come in other languages, but there's not a lot of writing on there, but it's something again that we can explore to see whether that can be developed up. And also, you know, using our resources like the 1-800 My Options, as once we give this information to workers or health workers, they can actually provide the 1-800 My Options information so that then those clinical pathways can be met by way of where to go, what the costs are, all that sort of stuff, and what languages are spoken at services. So shout out obviously to Carolyn and her team. It's such a great resource and we'll be heavily dependent on that. Yeah, so if you've got any questions, we're happy to answer that, but thanks for allowing us to share what we're doing.
So you picked up the question that came from Jackie Cook at Melbourne Uni, about Jacqueline Cook at Melbourne Uni, doing research into what people really want to know about LARC. Are you familiar with her work? Someone was asking. Jackie Coon was asking.
I think Frances picked it up.
Sorry, yes, I did.
Yeah.
I know we haven't made contact with
Yeah.
her. I don't know her, but that sounds like a great idea.
That's
So
interesting, doesn't it?
we'll
Yeah.
do that. Yeah,
Yeah.
thank you.
Patty, that was me that brought that up. She's a researcher who works with Jane Goller and a couple other people at Melbourne Uni, and she's
great.
specifically working on basically the difference between what people actually want to know about LARC versus what is available in existing resources and how those two things don't join up very well.
That sounds perfect. Yeah, we've talked a bit about that gap. Yeah.
She's
Great.
presenting in Gippsland in April at our women's health, women sexual and reproductive health forum. But she's very happy to talk about her research, obviously, as researchers tend to be.
That's fantastic. Thanks for that.
Interesting to hear. I hadn't heard about her either. Maybe we could get her to come. And
I'll send through her or find her contact details and send them through.
Thank you, Sophie, because that might be really interesting.
I've added her email into the chat there for anyone who wants.
Great. Thanks, Kath.
Are there any other questions?
There was a question in the chat from
Another
Sonia.
one?
about LARC providers and IUD and implant inserters. So I showed the results for service provision for MTOP. We have done similar analysis for LARC, and yeah, it shows a similar pattern, just with more services than exist for MTOP. It's more or less the case. Also, there's a in MTOP there was a massive discrepancy between services provided in Melbourne, like the central kind of area. So it seems like a lot of people travel to Melbourne to get MTOP compared to the outer local government areas. The same thing happens for LARCs, but to a lesser extent. So that, I guess that, yeah.
Louise, you've got your hand up.
Yes, thank you. That was very interesting. I'm just curious to know about whether you found any data from the hospitals, the public hospitals, in terms of LARC insertion post-delivery.
We haven't gone down that path yet. It's certainly, we're looking at the community, on the ground community, not so much women who are going through public systems, but no, we haven't. It's possibly another outside of the scope of this particular.
Yeah, because most maternal and child health nurses, that's one of the first conversations they have with their, 6 weeks check and things like that. And yeah, do you know what I mean? So often,
yeah,
it's
I think
interesting.
the best practice guidelines, talking about contraception at the antenatal phase, and then looking at, going from there, and hopefully looking at contraceptive before women leave hospital after they've had their babies. But in reality, that doesn't really happen. And, there's a lot of people that just don't feel comfortable talking about contraception or anything to do with sex or sexuality. So that includes maternal and child health nurses and midwives. They're not all that comfortable in that space. But we have met with the Wyndham area, and they are extremely interested in what we're doing. But they also say, well, we don't really talk about contraception. We don't. And we don't even know if our new grads, the maternal and child health nurses that are coming out, have that in terms of their education. So that's what we're finding out now. We don't know why that is, or whether that's about workforce capacity and just being so under the pump, because there has been a lot of staff shortages. They are certainly improving, and hence why they're interested in kind of coming on board with the project, so that, because they do have capacity. But good point, Louise. It would be really interesting to just to look at that, and what the waiting times are, and when IUDs are inserted, for sure. Thanks for that.
And Sarah has a comment, no?
Yeah, thank you. Just to add to that, we get some maternal child health trainees coming through to do the comprehensive course, because they can use it as an elective with La Trobe University. And it's really interesting to talk to them, because they don't really cover contraception in that kind of additional training that they're doing. So it's definitely an area that I think is untapped from an education perspective. And from a personal perspective, when I had my baby, I wasn't talked about contraception at all. And when I spoke to the maternal child health nurse, it was very much outside their scope to do anything to do with the birthing parent. So it's an interesting conundrum, I think.
It is, and you can see how it could be a system, a system improvement if we get maternal and child health nurses on board and have them feeling confident with even handing a resource out at that 4-week check just before they go back for their 6-week check with their GPs, etc. So it's such a simple little thing, but if you don't delve into the nitty-gritty, you don't know. So we'll be happy to share what we find out at the end of the project. And yeah.
Kath and I were at another meeting today. Sorry. Kath and I were at another meeting today, and this exact same thing was discussed. And without sounding like a broken record, we all know that everybody comes out of high school with the same crap sexual health education. So it doesn't matter whether you're becoming a doctor, nurse, midwife, maternal and child health care nurse, you all start on the same level.
It's interesting, isn't it, Sarah, that it's an elective, it's not core curriculum. And certainly our experience at RANZCOG was, we didn't even have reproductive health sexual and reproductive health as part of our core curriculum until we started doing curriculum development in the last 3 or 4 years. So
and the medical
it's
students don't have it either.
in recognizing it, you know.
Mm.
I had one question before we move off, and that was, are you going to have a bundle of resources then on your website, or that we can refer people to, or?
We haven't, well, it's in the stages of development, but the
Yeah.
idea is to have like a 2-pager, an A4 2-pager that is a very simple design that, you know, someone without a health background can understand why LARC and talk to a person about their options. And certainly there'll be an additional resource so that they can, a health, you know, one of the workers could actually go through and look at, you know, language kind of resources, videos that might be helpful, because there's so many different ways that we take in information. And yes, we are actually just doing a revamp of our website, and that's a possibility. We haven't really discussed that, or how that will be disseminated at this point.
It was just a plug that, you know, we've got like a central resource with Search that we could, you know, marry up resources so that people find them in lots of places, you know.
For sure.
It sounds like a great idea. Thank you both very much for coming. I was really interested in that epidemiology, and in fact, Frances, you know, the work you've done, you know, it interdigitates a bit with one of the publications that I was just going to draw people's attention to, and that's we've sent out 2 publications on our links. One recently published in January of 2024, changes in the numbers of hospital-based abortions and outpatient early medical abortions in Victoria. And this was a retrospective cohort study that I was involved in with Lisa Hui from 2012 to 2022. And we wanted to look at the concept of, you know, has medical abortion made any impact in Victoria? And a secondary question, did the pandemic make any difference? And the data that was mined for this was the Victorian admitted episodes data set, which is the VAED data set, because you probably all heard us banging on continuously that it's really difficult to get figures for actually how many abortions are being done, because the Medicare for an abortion is the same item as for a curette for a miscarriage, for example. So it was always really difficult, and it was really Lisa Hui who had the brainwave to look at it in this way. And we also looked at the pharmaceutical benefits scheme, because you'll be aware that MTOP was registered in 2012, but then wasn't floated on the PBS till 2015, and what effect that had. And I just think it's a real the importance of this article is that it's a real pat on the back for all of you providers, because it has really shown that in that period, 2012 to 2022, the incidence of hospital admitted abortions was just steadily going down, and there's a concomitant increase in the number of medical abortions being performed. And there was a big increase during the pandemic. What we also saw was that, as you all know, that there were a lot of closures of private providers during the pandemic, and we might have expected this enormous surge effect where the public hospitals, which were really under the pump anyway, would be having to pivot to do more and more abortions. We did the same number, and we didn't see a decrease in the demand, but we didn't see an increase in the demand either. But what we saw was an increase in the number of medical termination of pregnancy. In the first month or so of the pandemic, everything went quiet. The number of hospital interactions went down, and the number of medical abortions through the community also went down. But then there was a really big resurgence. And you might remember that the world finally, and Victoria in particular, finally understood what telemedicine could do. And there was a real uptick in that. So the other interesting thing is that the number of total abortions is pretty steady. it's sitting at around about, and the proportions for the gestations are also really steady. So sitting somewhere between 1,380 and 1,500 abortions per year, with a bit of a flex up and down each year. And the proportions of the gestations sitting at around about the same, which is interesting, given that often there is a narrative that since abortion law reform, the number of late gestation or late term abortions has become out of control or whatever. But the other thing was, and you brought that up really well in your analysis of the Western districts through the snapshot of the Western Public Health Unit tonight, that it's not equitable across Victoria. So there's a lot more provision in the metropolitan areas and then quite a rapid downturn. And certainly that is upheld by the work that 1-800 has shown us in the mapping of areas where there's been fewer providers. But the comment was that we don't have the numbers for other states, but Victoria put in a lot of effort in terms of educating and developing MTOP providers pre-pandemic. And then the critical mass got a bit bigger, more people came online, and they're suggesting that this is replicated throughout Australia, but it would appear that Victoria actually was quite well prepared in terms of what was done. So I think it was a really useful little snapshot of the 10 years, with the expectation, if things continued, that the level of, it's approximately a third of women are now considering an MTOP, and that's lower than European communities. But if the trend continues, that we would expect in the next 5 to 10 years that a great many more people would be choosing MTOP as their preferred methodology. So I thought that was great that got aired recently, because it's you know, a bit of a good news story. And I wanted to say that each and every one of you have been involved in that. Did anyone have read it, have any questions about it, or any comments? No, I think we're not. No. And the other one I just wanted to draw your attention to was another piece of research that we participated in through the hospital here, which is not usually the level of gestational work that we're usually talking about in the network, but I thought it would be of interest to you. And that was the publication of our social work team looking at the abortion care at 20 weeks and over in Victoria. And they have done a thematic analysis of both healthcare providers and women who have experienced a post 20-week termination of pregnancy in Victoria, basically through our service, and to see what themes are developed. And so there are 2 publications. The first one has now come out in BMC Pregnancy and Childbirth, again in early 2024. And this is the result of the interviews with the healthcare providers, midwives, nursing, social work, Aboriginal clinical health providers, and medical providers. And really just summarizing, there were about 3 definite themes that were identified: that being committed to quality care was incredibly important, and that most providers demonstrated a philosophy of a holistic healthcare approach to the patients, that it was difficult to provide this amount of, it was difficult to do this work, and it was difficult to sometimes be a provider in this area. And they identified different roadblocks and noted that regional and remote women tended to present late because they didn't have any access to an early ultrasound scan or a provider that would escalate their request for an abortion earlier, and that there were some definite areas or pockets of areas across Victoria that were easily identifiable as the areas where we saw most of the patients. from, and that most of the participants felt well supported by the team to provide the care and to reflect on the ethical challenges. And then the final point was that there was an overwhelming theme that the limited abortion workforce capacity in the wider, I said the wilder healthcare system, I meant the wider healthcare system. So beyond one tertiary hospital, that no one else was providing this, and so that it by nature became very inequitable, sorry. So those were the major themes, and the next one to be published is the analysis of what were the major determinants of causing advanced gestational age at the time of presentation. And so we can report on that later. Any comments or interest in those? But you can certainly have a look at them on the link that Kath gave. No. So at this point in the meeting, we usually go around, it's like a round robin, around the state, and ask if anyone has anything they want to share in terms of local developments, or the commencement of a service, new hubs starting. Kath, would you like to talk, just to start it off, about the 2 hubs that we had chats with this week?
Yes, I think the 3 new hubs were mentioned at our last meeting, and we've had contact with all of them actually. And just this week we've had a discussion with DPV Health, which is I always get it mixed up if it's Wallen or Epping, but with DPV and Nexus Primary Care, they're Wallen, and DPV are Epping. And both of those have been allocated new funding to identify as a reproductive health hub. And each of them also has a pathway for early medical abortion and LARC. But just having some more EFT resources will enable them to set up a nurse-led model, and there's potential for developing that model of care across different sites. And so we've just started a conversation with both of those services. And also I know Sunraysia was mentioned at the last meeting too, and they have just recently appointed a nurse into that position, and I'm pretty sure she's not here, but yeah, so look forward to developing that work with those 3 sites, as well as the various sites we've got represented around the room, and everyone else really. And Kathy's got a hand up.
Kathy.
Oh, yes, I've got to go to another meeting, so I thought I'd just jump in quickly if that's okay. You're probably aware of some developments within the service at Peninsula Health around the use of methoxyfluorine for IUD procedures. So we started doing that in July of last year, and it's been really well received and very simple product to use. So we're hoping that other services will also initiate that if they haven't already, because we have clients coming from New South Wales and other parts of the state that have heard about the service and would have like to try this method of pain relief.
Yeah, thank you, Kathy. We did a feasibility study here at the Women's and found it very helpful, but we also found that most patients didn't need it. Do you offer it to everybody?
Well, we do. People know that it's available.
Yeah.
The people that find it most beneficial are those women that perhaps have painful periods anyway, and potentially have endometriosis or something similar. And so they tend to have experience of quite a bit more pain during insertion and afterwards, actually. So it seems to help a little bit for those women. Women that have had previous vaginal deliveries don't seem to need it at all. But there's some women that have had difficult experiences in the past that have a lot of anxiety around having the procedure done, and whether they're multis or nullips, and so it is there for them if they choose to use it. Yeah.
So and I think if the media about your services to be is correct, that your hospital's offering it for free to patients. They don't pay for it?
Yes, that came as a surprise to me when I heard that media report, but apparently yes, we are.
Okay.
So yeah.
Because to answer Siobhan's question, it's $53 a unit, Siobhan. There are actually two strengths, because the other thing we find in our feasibility study was that the average number of puffs was 3 per insertion, and it can last for 20 minutes, the 3 ml aliquot. But I have just recently had a talk, or a meeting rather, with the company rep, who assures me that they have a smaller aliquot of 1.5 mils, which would last about 10 minutes. And we're just trying to negotiate with them for a cheaper price for that. Yeah.
Yeah, I agree that could become an issue. And I don't know whether, I don't know exactly what happened. But until that point, until that media report, we were charging the patients an out-of-pocket cost for that.
So maybe if I went online and said we were doing it for free, I could shame our lot.
Potentially, and we use a maximum of 3 mils, and now that we've been using it for a little while, we do get women to use, take at least between 4 and 6 puffs before we actually put the device in. And for me, I always feel more comfortable putting the speculum in first, so that they're still able to give consent for the procedure, that they're wide awake and that they can still give consent, I guess, for the insertion.
And thank you, Sarah. Sarah's just pointed out, and I'd forgotten that too. The rep had told me that there is actually an in-service from Penthrox tonight at 7:30 if anyone is interested, about safety and procedural basis for it. Yeah. I'm also going to explore how Ambulance Victoria gets bulk. They get a bulk order, because as you know, the ambulances use it really frequently. So there must be another way that we can order this.
There must be, and I think it's something that they may be open for negotiation. But the other thing is, I know, and this may not be correct, but when we purchase it with the charcoal adapter, which apparently is safer for healthcare workers, but I'm not sure that paramedics have access to that. I think it just, if it comes in a doctor's bag, it doesn't have the charcoal adapter. So I think that's something that we really need to be careful about.
Yeah, we would need to use the charcoal adapter. Apparently the price point difference is 60 cents, which isn't a great deal. And for some reason, the Ambulance Victoria don't use the charcoal adapter either. So it's quite interesting, and there's a lot in it. And one of the other things that we're looking at is how to ecologically dispose of all that plastic and all that unused greenhouse gas.
Yes.
Which has to be
considered. Yeah. We initially wanted to use nitrous oxide because we have that pumped through our walls, but because of the aerosol risk with COVID, that was declined. So that's why we went in the other direction. So I'm hoping that over time they may think of something that's a little bit more environmentally friendly.
There's 2 hands up, Paul and then Angelina.
Thanks. It's anecdotally, the reason I was late is we did our first IUD with using Penthrain this afternoon, which worked absolutely magnificently. Question there about recovery, etc. We had a chat with this lady. She was a NELIP, some anxiety. She was already anxious when she got there. She was anxious after waiting for me for 30 minutes. But she had someone to take her home, basically. So, we insisted that she couldn't drive. There was someone to take her home, and she was fine and recovered very quickly. But it was amazing to see how she relaxed and everything relaxed, and I relaxed as well at the same time, and not because of the Penthrain. So I think certainly, and it was interesting because we talked at the conference in Sydney, about using Penthrain, and I guess this is a case in point compared to the one in January, who left in tears and anxious and upset and very distressed because we couldn't fit it in someone who's a NELIP. So I think it just pushed us towards using it. Cost, I'm not sure. Kath might be able to answer that one. Not quite how we managed it this afternoon. I don't know. No money changed hands. And the other thing, just in news, which you're probably aware of, after several years, for some reason, LRH here locally have decided they will offer a stop service for the first time since I don't know when. I don't quite know how we managed it, but eventually perhaps pressure on the CEO from myself and others. He thought we were doing them. I convinced him that we weren't. And so it happened very quickly, albeit the first referral using their special email that we were given. Turned out that was the urgent referral for the orthopedic service. So they were a bit nonplussed to be asked to do a stop instead of a THR. But anyway, we've got it sorted out and we've done 3 or 4 without any problems.
So you've done 3 or 4 lists, is that right?
No, 3 or 4 patients.
Oh,
No.
Okay.
The issue is still staffing, and mainly the anaesthetist. Apparently, there's only one who's prepared to do this, provide this service. So that's the stumbling block.
But at least you've started, you know.
Started, that's right. It started.
Yeah.
Yeah.
So at the moment, Paul, do they fit them onto other lists?
They tack them onto a list, I think, basically depending on the staffing, those who are prepared to provide that service.
Yeah.
It's kind of got to be manipulated to make it work with the relevant staff who are prepared to help, and obviously before, well, up to 12 weeks and 6 days, basically.
Well, I want to thank you all, Paul, all the team down there. That's just, it's been years and years of advocacy and stating the bloody obvious, constant, and not looking down. So well done, and it's definitely a major step forward. So thank you very much. And anything we can do to help. I did reach out to some of the providers at the hospital, but I will reach out again, see if we can help. Angelina, you got your hand up?
Yes, am I there? I'm Ange Juice and I'm a community health nurse in Swan Hill, Northern Victoria. And we're really, really excited here because Holly Timmins, who's online tonight, is recently endorsed as a nurse practitioner in sexual and reproductive health. So we are really, really excited about starting this new service here in our rural town. And I know there's quite a few of you here who know Holly and have supported her in many ways. And seriously, our service is so grateful for everything that, you know, and support that you have provided Holly over the last, I don't know how many years and hours that she's put in. So yeah, new frontier, and very excited for obviously our local community, and particularly the services we'll be able to provide our women now.
Holly and also Sarah and others, you know, to see how many candidates are now coming about, you know, making use of the scholarships that were offered, etc. It's great. It's really great.
And yeah, it sure is. Thank you, everyone. And Sarah, you're next.
Yeah, you've done the hard road, Holly. So great to have you on board, and well done for all your efforts in your study.
Yeah, and yeah, that's right. And it'll be great, like Ange said, a great service for our town, being so regional and remote. So it's exciting. I'm up to week 2 tomorrow, Thursday. So only just new. We're still getting it up and running, and
great.
Lots to do.
Now I'm just aware it's just turned 7 and we are known for our punctuality. So does anyone else have anything that they wanted to share from their area, or just before we close? No, I don't think so. I don't think so. Well, look, I would just like to close tonight just remarking that we've had 27 participants, highly representative of the Victorian community, if we look at you all on the map. And I just want to close by saying that we're really thinking about everybody in the mid and western parts of the state that are facing a difficult day tomorrow. At the very least, and our thoughts are with you all. Our next meeting is June the 4th. It wasn't the 11th, yes, it was the 4th, yeah. June the 4th. We will be in touch before then. Take care, everyone. Bye for now.
Thanks all.